All right, are you guys able to see the slideshow? No issues?
Yep.
Perfect, that's what I like to hear. So again, we're talking about the pulmonology, the pulmonary system. We're going to review some airway. We're going to review the upper airway. We're going to review the lower airway. We're going to look at some of the common medical conditions that we get called to, especially when it comes out as a breathing problem. And some of the things we should dive a little bit deeper into as far as the respiratory system and how our body really takes oxygen in and how it really turns and does the transfer between carbon dioxide and oxygen within our lungs and is broke down our alveoli. So a lot of it's review. Like I said, some of it we're going to go through kind of quickly. Some of the stuff we might not go as quickly through. If you have any questions, as always, please speak up. Stop me during the slideshow, and I'll try to answer the questions to the best of my ability for you. Or if you want, get a hold of me after class. I always ask at the end of class if there's any questions, and I can review with you then as well. I don't anticipate tonight will be super long. Generally, our classes are slotted from 6 to 10. This semester, there is no way I can get you guys to maintain focus for 4 hours. So I try to keep it to 2.5, 3 hours if I can, just knowing that, anything past that, you're not going to really retain any information. So I'm going to try not to keep you till 10 unless for some unforeseen circumstance you guys want me to do that. So any questions about anything before we get started? As far as the class itself, medical emergencies, any issues you guys have had with anything? I didn't think so. Let me turn my volume up real quick just to make sure I can hear you guys. So in case somebody does say something, I won't have any issues. All right. So what we know about the respiratory system now, right? We know that we take in oxygen. Our body uses it. We carry it in our bloodstream in layman's terms. When we are done using it, it is then transported through our lungs. It turns into carbon dioxide, transported to the lungs, rejuvenated, if you will, turned into oxygen, and essentially reused. It's a closed loop system. It's how our body functions, right? Our hemoglobin carries oxygen, but remember, our hemoglobin can also carry carbon dioxide as well. That's why sometimes a pulse ox might not be the best indicator of how our patients are truly oxygenating. That's why, we always say, let's get an end tidal reading, because pulse ox just measures the amount of hemoglobin that's saturated. It doesn't measure the amount of hemoglobin that's saturated with oxygen, just the amount that's saturated. And remember, with anything that we do, what are the two things that our body requires to function? We need energy. What are the two things that make energy? The two big ones for our brain to function. Dig down deep from last semester. I know we've had a long break.
Need sugar.
We need glucose. What else? One more. We need oxygen. We have to have sugar and we have to have oxygen for our brains to function. For every 2.5 to 3 minutes that our brains are without oxygen, we can start to see cells deteriorate within our brain. So we do have to oxygenate. Respiratory conditions, especially with some patients, think of your patients that have COPD. Think of your patients that have underlying cardiac issues. And why that's important when we talk about the respiratory system is if their lungs aren't working the way they do, such as a patient with COPD, maybe they have a hardening of the lungs. Their lungs aren't elastic as they once were. They're not able to fully expand. They're not able to fully shrink down. That means they're really not going to get a good breath. And the problem with that is they're not bringing in the amount of oxygen they should. That's why you'll see a lot of patients with COPD in the high 80s on pulse ox is because they're just not bringing in the amount they should. And that's normally where they sit. The problem with that is, as an EMT, we see somebody with an oxygen saturation of 88%. The first thing we think is, oh my God, I think back to EMT school, I've got to put this person on high flow oxygen. With COPD patients, a little bit different. We don't have to put them on high flow oxygen. That's where they're normally sitting. That's why one of the most important questions I ask my patients that are having breathing problems, and especially if they are on oxygen, is, hey, what's your oxygen level normally? And they'll know. A lot of times they will know what they usually sit at. And a lot of times it's between 88 and 93%. Why cardiac conditions can lead to this? Well, our heart does what? It receives blood from our body when our body's done using it. It takes that blood, pumps it through, shoots it over to the lungs, right? The problem is if our heart's not in the best shape either, it's not doing that job effectively. It's not getting the blood to our lungs that it should, which means our body isn't receiving the oxygen in our lungs because we're not able to pump it effectively to the body or to the lungs. Cigarette smoking, anytime type of smoking at all, honestly, is one of the highest risk factors when it comes to people with respiratory disorders. Another one is environmental pollutants. So pollen, smoke, especially like bonfires or anything like that, or maybe somebody's burning leaves or something like that. That smoke generally tends to irritate patients with respiratory issues as well. Any sort of smoke, you'll notice a lot of times those patients will begin hacking, begin coughing. They're not able to really take in the amount of oxygen they should, and that's because they don't have the lung capacity to be able to filter out what's going on. They don't have that process, and a lot of times that's with our elderly and younger populations that you're going to see this happen. So what happens is we have an upper airway and we have a lower airway. Our upper airway is responsible for warming and humidifying incoming air. So if I breathe in really cold air, what happens? Have you ever been outside in -20-degree weather? You take a big puff of air in and your nose hairs feel like they're freezing all at once. It feels like little icicles in there. Or when you're breathing, the back of your throat starts to hurt because it's freezing up. It's because your body's job is to try to humidify that and warm it before it enters your lungs. That's the job of the upper airway. And inside our nose itself, our nostrils, we have hair follicles, right? Whether you like it or not, they are there. Those hair follicles are designed to capture any sort of irritant, to capture any sort of dust particle. They're meant to filter them out before they go into our upper respiratory tract itself. We obviously have a nasal cavity, which is divided by a septum, which is the middle of our nose, right? We have our left nair and we have our right nair. One will generally always be bigger than the other one. So that's why when we talk about like putting an NPA in somebody or nasal airway, a lot of times if it won't go in one nair, we try the next one, just because anatomically one side of ours is always bigger than the other. Breakdown of what our upper and lower airways look like. So obviously, upper airway, you have your nose, you have your mouth, your different tracts, where we're going to go into our trachea. As you can see, our trachea down there where it begins to turn blue. We have our cricoid rings. In our younger patients, they don't have those developed yet. We branch off into our lungs. Our lungs end with this circled picture right here, our arteriole. They end with essentially the spider web, where arteries connect to veins, where oxygen, poor blood comes in, is essentially transformed into oxygen-rich blood in our alveolar ducts, and then it is pulled out and sent back to our body. That is the job of those little grapes, those little suckers, the alveoli, what I call them. It is nothing but a fishnet or a spider web of arteries and veins that are intertwined with each other. So when you hear of like the pulmonary capillary bed, that's what you have to think of. Anytime you hear capillary bed, that's what's happening, is you get those arteries that have been shrunk down so much, they now meet up with veins that have been shrunk down so much, and they exchange oxygen-rich blood or oxygen-poor blood with oxygen-rich blood. Within our lungs, important part of this slide, and within our upper airway as well, we have these finger-like, think of like blades of grass almost, called cilia. And the job of the cilia is to essentially just wave back and forth. And I'll put a video of this on D2L as well. Their job is to filter out anything that made it past our nostrils, that made it past our nasal hairs. And their job is to essentially, once it's captured, they'll just continuously wave back and forth and essentially expel it out of our system. The problem with that is our cilia also rely on a layer of fluid underneath them called a sole layer. It's essentially a layer of gel coating. The issue with that is in some respiratory patients, when they're really dried up, like especially if you've ever heard somebody cough, it's a really dry cough, they've usually, used up that sole layer. They're just really dehydrated. So sometimes in our respiratory patients, it's not a bad idea to start an IV on them and just give them fluid TKO, because that can assist in rehydrating that sole layer as well. So remember, that sole layer is like a gel layer. And again, like I'll put a video of that on D2L for you guys to review. So anatomy of the upper airway, again, a little more expanded view. Nasal pharynx, which is right behind our nose. Oropharynx, which is right behind our mouth, terminates at our essentially vallecula, which is where our blade fits when we're going to intubate somebody. When we're talking about the MAC blade, it fits into the vallecula. A Miller essentially grabs the whole epiglottis and lifts it up as to where MAC fits in that vallecula. The glottic opening, which we're used to seeing when we go to intubate somebody, surrounded by two white fibrous bands called our vocal cords. Perfect view for us to see to be able to intubate somebody. We have our cricoid cartilage and our cricothyroid membrane. When we talk about a cricothyroid membrane, if you can see that right there, let me get my marker out, or my laser pointer. Right here is my thyroid cartilage. Right here is my cricoid cartilage. Right in between there is a really soft spot, okay? That's when we talk about like needle crics or needle cricothyrotomies. That's the spot that we are shooting for, where there is no hard cartilage that we can pass through. So anytime you hear of a needle cric or needle cricothyrotomy, that's the anatomic position or anatomic landmark that we are shooting for, which we'll get into later on in this semester as well as we practice skills with that. I talked about our cilia, wave back and forth again like finger-like structures, removed via the digestive tract. So once the pollen or whatever, it might be dust or whatever, if it gets trapped in that cilia, those waving blades of grass back and forth, it essentially is moved out into our GI tract where we then eliminate it. Please, anytime you see a name like Kisselback's plexus, you want to automatically remember that or write it down. Yeah, I'm sure it's important for something. As far as paramedicine goes, don't spend too much time remembering that. It's not something that is essentially pertinent when it comes to our education. So please don't think that you need to remember that for a test question or anything like that. We do have sinuses, which are essentially air cavities in the front of our head, our sides, our cheeks. When it comes to sinuses, has anybody in here ever had a sinus infection? What's it feel like if you get a sinus infection? Who can describe it to me?
Congested and full.
You feel congested and full sometimes, right? And it almost feels like you have snot or something in your sinus tract, right? That you just cannot get out, right? That's because those
like it's in the back of your ears also.
Yeah, and that's because you have ducts back there. And a lot of times it's because those air cavities do have mucus in them and they have no way of getting themselves out with you blowing and sucking in constantly. So a lot of times that's why we're placed on antibiotics to fight that infection and reduce it down and rejuvenate that air cavity and bring it back to what it should be. When we talk about any one of our senses, so touch, feel, sight, smell, there are different nerves within our body. Now, nerves has its own chapter of itself, so don't freak out that we're not going to cover that yet. But olfactory is one of your nerves, and that has to do with the sense of smell. There's 12 different nerves that we're going to go over during this semester, and the nerves are pretty important that you remember. So when we get to that point, make sure you're writing those down or taking notes on them because they do make a difference. All right, so our lower airway starts at our trachea, okay? Our trachea, and you can feel yours right now. You might have to tilt your head back a little bit. Well, if you have baby fat under your neck like I do, you can feel these hard rings along your trachea, right? And they're every so often. And you can feel your trachea where it gets softer towards the top, and then it gets really sensitive towards the bottom. Those C-shaped cricoid rings are there to help either move air in and out, or if food or anything touches your trachea, it starts and begins a cough reflex, right? Who's ever ate or drank anything and it goes down the wrong tube? What do you automatically do? You start coughing, you start hacking, you almost want to throw up. That's because there's nerve endings along those cricoid rings. And their job is, hey, anything other than air, I got to start coughing. Something's not right. Younger populations don't have that. They're still developing. That's why a lot of times when we talk about like innovation on pediatric patients, they were not very well liked or let's say cuffed ET tubes were not very well liked because they thought as you inflated the cuff on a pediatric patient that you were cutting off blood supply to their trachea. That's since been disproved, but that's why you'll see some older Broslo tapes still also show don't use an uncuffed tube or don't use a cuffed tube on a pediatric. We use uncuffed. That's the reason behind it is because they thought it cut off blood supply when you expanded the balloon. So at our carina, which our carina is where our trachea branches off into our left lung and our right lung. That crossroad that you come to where you got to turn left or you got to turn right is called our carina. It's really important that you remember that. We can either go to our right main stem or we can go to our left main stem. Now, again, when it comes to intubation, why is it more times than not, if we wrongfully intubate somebody or wrong position, why is it that it goes down to the right more than the left? What's the reason behind that?
It's more of a direct shot instead of shooting off like the left side.
Absolutely. It's almost a straight shot down your trachea into your right lung, as opposed to your left lung, which kind of curves off a little bit. You really, have to really try to get a left main stem intubation. But that's why when you intubate somebody and your breath sounds only on the right side, we say, hey, let's pull our tube back a little bit. Let's deflate our balloon. Let's pull our tube back a little bit. Let's reinflate and see if it was user error at that point, right? This is what I'm looking for. When it comes to bronchi, now when we talk about bronchi or bronchus, what we're talking about is let's follow our trachea down here. So our trachea goes down. We have our carina where we go right or left. Our bronchus are essentially the passageways from the trachea into our lung, right? At the end of these bronchus begin our alveoli, begin our alveolar ducts. So at the end of these, you will see all those little clusters of grapes surrounded by spider webs, which are our capillary beds. It's pretty self-explanatory how that works. Our air comes in, right? Air comes in here, goes all the way down, goes into both sides, follows our bronchus down into our alveolar ducts, meets our alveolar sacs, which is where our capillary beds are. This oxygen is essentially converted, or carbon dioxide is converted into fresh oxygen and sent back through the body. What happens to the carbon dioxide? It's expelled out in reverse order, and then we are able to breathe out. A good example, if anybody works on a fire department or if your EMS agency carries a 4-gas meter or a gas meter itself for CO, maybe on your first out bag, grab it and breathe into it. Find the sensor and breathe into it. I guarantee that thing will start alarming. It's because you're breathing carbon dioxide into it. You're exhaling. It'll start alarming because the oxygen level at the sensor is dropping because you're breathing carbon dioxide into it. Good cutout of our cricoid rings as well and how they are shaped. The back of them is pretty flat. You can see the smooth muscle right there as to where the front has a more rounded horseshoe appearance to it. And then if you look over this diagram right here, when I talked about cricothyrotomies, this little gap right here is the spot that we shoot for. So right below you, if you feel an Adam's apple, there's a soft spot right in there. You can actually feel it on yourself, but it's really soft. It's really spongy. It's a lot easier if you tilt the person's head back to find that, but that is the little spot that we're looking for. So when we talk about these little lollipops, right, at the end of the bronchus, when our lung tracts come down, we have about 300 million of them within our lungs, if that tells you how small they are. Our lungs aren't gigantic, but 300 million is a pretty large number, so that means that they're pretty small. God, I wish we could have done it with you guys. When I went through paramedic school, we had a cadaver lab. And in that cadaver lab, obviously there were lungs, there was a heart, and we could actually inflate the lungs to see how much they truly expanded and to see overinflation. It was probably one of the coolest things I think I've ever done because you really get to look at human anatomy a little bit more. So if you ever get the chance to go to a cadaver lab, I know it sounds kind of barbaric, but it's really not. By all means, go to do it because you learn so much about anatomy. Close up of our alveoli, again, little clusters, little grape clusters, what I call them, surrounded by our capillary beds or little spider webs, where we exchange carbon dioxide for oxygen. The problem is in people that have CHF, these little clusters, those little balls there, begin to collapse. When that happens, it's a condition called atelectasis. Atelectasis is alveolar collapse. Now, what happens? What sounds do we hear if somebody has CHF? Say they've got their retaining fluid in their lungs and they try to breathe. What sounds do we hear?
Would it be crackles?
Crackles. Now, imagine this. If I keep a glass of water in front of me and I put a straw into it and I blow into that straw, it's the same concept. It's the same sound that I'm hearing, except I'm listening through the body, right? The reason that there are crackles, that sound is because those alveoli are trying to open underwater and it's creating a popping sound. They have to pop open with so much force to allow oxygen to come into them. That's why people with CHF have a really hard time breathing until we put them on CPAP. So imagine water or pressure all around these. They're not able to open. We put them on CPAP, we push that water and fluid away, and then those alveoli are able to open freely. So in between, we have different layers of our lung, right? We have an outside layer, we have a middle layer, and we have an inner layer. No matter what tissue it is, you always have an outside, a middle, and an inner. What keeps these lung tissues from moving or from sticking together or from creating friction is a fluid called surfactant. And a lot of times, if you've ever heard of like a pleural rub or something like that, or an infection of the pleural lining, pleuritis, that is because that surfactant has diminished on the linings of the lung. And so when they breathe, it honestly hurts them because the friction of the linings of their lung are rubbing together. That's why a lot of times these patients will be sitting in a tripod position, is because when they lean forward, their lungs swing forward. As their lungs swing forward, there's no pressure on them. So their lungs are able to expand a lot easier. Or they might tell you, hey, it hurts really bad when I breathe. My chest hurts when I breathe. Automatically, as paramedics, we want to go to, oh my God, it's a cardiac condition. It doesn't always have to be cardiac to cause some form of chest pain. This is going to be a really sharp, pleuritic type chest pain. When I say sharp, almost like stabbing pain. And they'll describe it as, my lungs feel like they're getting stabbed. Again, that's generally caused by an infection that is causing a reduced surfactant level in the linings of the lung. Pretty important. Go back to your EMT school days. Right lung has 3 lobes. Left lung has 2. Again, please remember that. Connective tissues are pleura. That's why when I say pleuritis, that is a infection of the connective tissue or the linings of the lung. That pleural fluid, surfactant. This is going to be opposite right here than what we're used to. So arteries in the body. Arteries usually transport oxygen-rich blood, right? That's what arteries do within our body. In the lungs, arteries carry oxygen-poor blood. It's the only time it'll happen. So when we talk about our pulmonary arteries, that is coming from a place where, we used up all this oxygen-rich. It's entered our bloodstream. It's got to go back to the lungs. It's got to go through that cycle, through that respiratory cycle. So it's opposite in the lungs. Body carries oxygen-rich blood in the arteries. Lungs carry oxygen-poor blood in the arteries, and then veins in the lungs, carry oxygenated blood. So remember, they're always flip-flopped. Body, oxygen-rich in the arteries. Lungs, oxygen-poor in the arteries. Body, oxygen-poor in the veins. Lungs, oxygen-rich in the veins. Say that 10 times fast. I almost got tripped up. So do not confuse ventilation with respiration. Ventilation is actually the mechanical process. When I talk about the mechanical process, that is our diaphragm lowering. And what happens is through negative pressure of our diaphragm lowering, we actually suck air in. That's how we breathe. It lets our lungs expand. When we refer to respiration, not ventilation, respiration is actually the process of exchanging carbon dioxide and oxygen within the lungs. Don't get those two confused. Ventilation is a mechanical process, where respiration is the cellular process. We have inspiration, we have expiration. This depends on the air pressure within the thoracic cavity. And when I say our diaphragm just below our lungs, again, if I breathe in, right, you can feel your chest rise, you can feel your diaphragm lower. And then when I breathe out, my diaphragm rises and pushes air out of my mouth, pushes air out of my lungs. Inspiration, active process. We really, have to breathe in. Although it is an automatic process, our body still does have to tell itself to do that. As to where expiration is a passive process. We generally won't hold air in unless we're forcing ourselves to, right? Unless we're holding our breath. Expiration will always happen. If your mouth's shut, it'll come out of your nose. If you're talking, it'll come out of your nose. If your nose is plugged up, it'll come out of your mouth. That's just how our body works. It has to get that air out of our body. Inspiration requires ATP. If you remember what ATP is, it's energy. As to where expiration does not require energy. Now, we can overinflate our lungs when we breathe. There is something called the Herring-Brewer reflex. It should be in here in a couple slides, but Herring-Brewer, what that is these receptors within our lungs, within the pearl linings of our lungs, that if we bring in too much air, it'll actually, they're stretch receptors. It'll stop us from pulling in air. So if I just sit here and keep breathing in, breathing in, breathing in, breathing in, essentially my body starts to slow down and won't let me pull in any more air, right? Like it almost seems like you're gasping to pull in air. That's because those stretch receptors are starting to go off and telling your body, hey, we're done. We can't take any more air within us. And again, a lot of times that is called your Herring-Brewer reflex. That I probably would know. And you need to probably write that down somewhere, Herring-Brewer. And when we come to it, I'll point it out here as well. We do have a residual volume of air that resides in our lungs at all time. Even if we expire all of our air out of our lungs, we have this little bit of air, residual volume, that maintains patency of our alveoli. If that wasn't in there, our alveoli would essentially collapse. And to pop that back open, we would essentially have to have CPAP or some sort of positive pressure to bring those alveoli open again. Remember, if those alveoli aren't open, we're not exchanging carbon dioxide and oxygen. Why perfusion is important with oxygenation? Well, blood carries oxygen. Blood carries all of our nutrients, right? So if you look up some trauma cases, and I'll try to show you this guy in lab sometime, there's cases where people have bled out so severely that their oxygen level has dropped. And it's not because their lungs aren't working, it's just because they don't have the hemoglobin to carry oxygen due to the extreme blood loss. So we have to make sure that we are maintaining perfusion as well. Now, that even though that might be a later sign of essentially bleeding out, a lot more things are going to happen at that point. But you can see oxygen saturation numbers begin to drop. You can begin to see end tidals start to creep up because we have more carbon dioxide than oxygen at that point. Oxyhemoglobin is hemoglobin with oxygen attached to it. As to where deoxyhemoglobin, hemoglobin without oxygen. And remember, hemoglobin without oxygen can attract carbon dioxide. Carbon dioxide is 3 times more likely to attract the hemoglobin than oxygen is. That's why it's really important. We go on like a call of people not feeling well inside of a house. They're all complaining of headaches. Get them out of the house, right? That's the first step. We get them out of where they're at, especially if they're all complaining of the same symptoms. I guarantee if you put them on a pulse ox, it'll read 99, 100%. Put them on end tidal and see what their end tidal reads. I bet their end tidal is really high because if there was some sort of leak inside their house, maybe carbon monoxide or whatever, you're going to see a higher than normal carbon dioxide level within their bloodstream. Changes in pH will change our respiratory pattern. So remember our pH scale, 7.35 to 7.45. Anything below 7.35, I'm acidic. Anything above 7.45, I'm alkalytic. So if I'm very acidic, that means I'm hanging on to carbon dioxide. So as our pH begins to drop, our end tidal begins to rise. Our body tries to get rid of it. How does it do that? It takes big, deep, and labored respirations trying to blow off a lot of that carbon dioxide. Same goes for if we become alkalytic. Maybe our end tidal is going too low, and our body tries to slow its breathing. Does anybody remember from last semester when I talk about HCO3 or bicarbonate, what the normal blood reading is of bicarbonate? If I was to tell you a measurement, does anybody remember that normal range for bicarb?
Is that the 19 to 24?
It is 19 to 24 is our normal level of bicarb. Good job. For perfusion, again, we have to have adequate blood, which this is a big debate within pre-hospital and hospital communities is in our severe trauma patients, why are we overloading them with crystalloids? Why are we overloading them with normal saline? That's not essentially what they need. They need blood replacement. Think of, and I saw it on Facebook today, and it was actually a really good point. If our body begins to run out of blood or we begin to bleed, as paramedics, we're like, I can fix this. I can start an IV, I can start giving you fluids, I'm going to fix everything. If your car ran out of gas, could you put water in the tank and it would function appropriately? No. We need blood to carry oxygen, not saline. Saline will not carry oxygen because it doesn't have hemoglobin. And so that's why in some of our trauma patients, it's a concern as well to monitor their oxygen saturation and their end tidal. Any disruption in ventilation can cause an issue. And this can be caused by mechanical issues. This can be caused by injuries, such as a flail chest, such as a tension pneumo. Maybe it's a airway obstruction. Those are considered disruption in ventilation. The problem is a disruption in ventilation leads to decreased oxygen and increased carbon dioxide numbers. Some of the patterns that we would potentially see, and I'll put a video up of these as well on D2L under pulmonology, Shine-Stokes respirations, so potentially indicating a head injury. And again, I'll put these up so you guys can actually see them, so it makes a little bit more sense instead of me describing them on a slideshow. Kussmaul respirations. We know Kussmaul is associated with higher levels of blood glucose than normal. They're trying to blow off the excess ketones. That's why they have that fruity smell to their breath. It's mainly senior diabetics. Central neurogenic hyperventilation. A lot of times your body will try to hyperventilate if there is any sort of CNS trauma, central nervous system trauma. Ataxic respirations are what also could be called Biot's respirations, and then apneustic respirations. And again, I'll place a video on D2L for you guys to look at this. And a lot of the stuff we will go over in lab in person as well, because it's a little easier to demonstrate and show you guys in person. And some of this stuff, again, I'm skipping over because it's maybe something that's not as important. This goes back to what I was saying with people calling. Maybe they're all complaining of a headache. Maybe they're all complaining of breathing problems. Is it safe for us as first responders to go in there if it's potentially causing some sort of respiratory irritant to our patients or causing an issue? Get as much information as you can as what's going on. If there's multiple people in the same household complaining of the same issue, you've got to start to turn the wheels in your head a little bit as if it is going to be safe or not. And honestly, in those instances, I'll knock on the door when they answer the door. I'll be like, hey, come out here and talk to me. As I'm talking to them, I'll see if they start to improve when they're in fresh air as well. Oxygen poor environments that we could all be subjected to, grind silos, this is Iowa, enclosed storage containers, any enclosed space with active fire. Why is that? Well, fire requires oxygen, so it takes oxygen from the air, right? That's why a lot of patients will suffocate before they are actually burned within a fire. Make sure you're wearing your proper PPE when it comes to potentially any sort of environment that could be life-threatening to you or your partner as well. And if you need hazmat, this goes back to operations with a paramedic. When you're going through paramedic, you're not a firefighter. You are a paramedic student. Do not do not feel that you can go in there and save the day. You have to call specialty teams out, and especially when that comes to the national registry test. That is what I see 9 times out of 10 is people will mess that up and be like, well, I'm hazmat certified. It's not talking about you. It's talking about in general. Use your senses when it comes to if you think something is going wrong. Our primary assessment, look at the patient's position. Are they tripoding when you get there? Are they leaning forward, which again, swings their lungs forward? They don't even know that it's doing that. It's just easier for them to breathe that way. So that's why they position themselves like that. Is this in the middle of the night and the patient has a bunch of pillows that they have to sleep on so that they're able to breathe easier? That's another indicator that they potentially have COPD. What do they look like? Do they look pale? Do they look cyanotic? Do their lips and their finger beds appear blue? Cyanosis is a very late finding of hypoxia. It takes a very long time to become cyanotic. That's a concern. If I go in and I see somebody that's that severe, yeah, let's figure out what the root cause is at that point, do a quick assessment, and move on to our treatment with our patient. Good example of a tripod position. Patient leaning forward. As you can see, your lungs will swing forward in your chest cavity at that point, making it easier for you to breathe. They don't have pressure, right? They don't have the weight of, a lot of times this is with heavier set people as well. When they're laying down, they get a lot of pressure on their chest just due to weight. But when they sit like that, the weight's not on their chest anymore. They're able to breathe easier. How is our patient acting, mental status wise? Put them on a pulse ox, put them on end tidal. Are they acting normal? Ask the family if the family's there, right? Do a good assessment. Get our vital signs. Use those in conjunction with what we think is going on with the patient. Remember to base your assessment around the chief complaint. They're complaining difficulty problem or breathing difficulty. Okay, I'm going to focus more on respiratory issues and cardiac issues. If they're able to speak in full sentences, that's a pretty good indicator that things aren't as bad as they could be. If they're speaking in 1 to 2 word sentences, that's a problem, right? Are they using accessory muscles to breathe? Are they having trouble breathing? Are they having nasal flaring? Do they have pursed lips? And any threatening conditions such as airway obstructions. All right, let's take a 5-minute break. I'm going to come through a lot of this stuff again. We're going to swing through pretty quickly. We're already at slide 50. We're an hour in. I don't anticipate we'll probably be here another hour, hour and a half, and then we'll get you out of here. But let's take a 5-minute break, and then we'll come back and finish going through the slideshow. Five-minute break, not hour, if that's what I said. All right, we'll keep trudging along here. So, in line with our primary assessment, obviously with our ABCs, and I cannot stress enough to you how much you guys need to revert back to your basics before we move on to advanced skills. So we look at the airway. Is there anything that's potentially causing any life-threatening injury or any sort of ventilation issue with the airway? Breathing. How is the patient breathing? Do they look like they're breathing irregularly? Do they look like their lungs are expanding? Are they breathing? Are their lung sounds adequate on both sides? Are they equal on both sides? Is their chest rise on both sides? Do they feel like they're short out of breath? What do their lung sounds sound like? These are all pretty important things. What is the color of our patient? Are they cyanotic? Does it look like they're struggling to breathe? That's when we can really dive into our secondary assessment. So what kind of medical history does our patient have? Go down our sample. OPQRST is more reserved for, I'd like to say, trauma assessments, but go through your OPQRST. When did this start? Anything maybe better or worse? If you had to rate your pain, how severe is this? Things that we need to figure out to try and build a differential diagnosis with our patient. Also, figure out, if you can, if they're not listing all their medications or you feel like there might be on more, ask them if you can see their medications. It's important as paramedics that we start to understand prescriptions and look at what those prescriptions mean and what those prescriptions start to treat. Ask family members that are around them as well. One of the things I like to ask my patients if they're having severe difficulty breathing, maybe they have COPD, maybe they have asthma, is I always like to ask them, have you ever been intubated before? Have you ever had a breathing tube put in before? Because that'll tell me how severe this patient could potentially get. Ask about a neb treatment. Have they taken neb treatment recently? Do they have an inhaler by chance? Do they take any cardiac medications? Have they ever had any cardiac conditions? Cardiac and respiratory goes hand in hand. So asking about one could lead to answers to the other. Leave no stone unturned when it comes to assessment with breathers, because breathers can go downhill really fast if we don't manage them appropriately based off of what we know about them. Pursed lips, a lot of times you'll see that with patients complaining of COPD, and that's a lot of times they're creating their own back pressure. When they purse their lips and breathe through that, it's because they don't have the compliance within their lungs. So they create their own back pressure to allow for exhalation, right? Look for any signs of swelling. Look for any potential signs of infection. Maybe they've been sick recently. Maybe they're running a temperature. Look to see if you see any tracheal deviation if they're having trouble breathing. If you see any jugular vein distension, maybe they do have some sort of tension pneumothorax. Maybe it's a taller and lankier person, and they potentially have a spontaneous pneumothorax, which we know is pretty common in taller and lankier people. So I would say, like Eric Hansen, the news anchor, that he's a perfect candidate for a spontaneous pneumo. Look at their chest. Look at them breathe. You know, one of the famous things that we do in all of our PCRs, and if you say you're not guilty of it, I'll call you a liar, is we document respirations 16 or 18, or even 20 if we're feeling a little froggy. Count breaths. You guys are going through paramedic school, your students. We should be able to look at somebody's chest and actually count their respirations and see if they're truly having problems breathing or not, and see what their respiratory status truly is. Palpate. Why is it important that we palpate? Because air can leak, right? We can get what's called crepitus. We can get what's called subcutaneous emphysema. Any sort of crepitus could indicate potentially a flail segment of their ribs, right? When you hear bone on bone grinding. Anytime you could feel the skin and maybe feel crackles, almost like Rice Krispie treats under their skin, they pop when you touch them. That's a sign of air leakage into the layer of their skin. Could either be an upper airway issue or even a lower airway issue, but it is a potential life-threatening emergency, right? That's leaking air that they're not able to breathe. Percussion, we don't really do a whole lot anymore, and it's, tapping certain parts of their chest, listening to the sound that comes back, listening to how the thud sounds when you tap it. We don't really teach a whole lot of percussion anymore, but we do teach auscultation, right? We listen to lung sounds. That's what we should be doing. Listen to tracheal sounds as well. Put your stethoscope over their trachea. See what the sounds sound like. See if it feels like it sounds like air is moving freely. One of the best places to listen to lung sounds is in the armpit. You do not have a lot of tissue between your armpit and the lung. There's not a whole lot there. So it's great to listen to lung sounds. When you listen to the front of somebody's chest, you're really listening to the lower part of their lungs. As for if you listen to the back under their shoulder blades, that's more at the top and higher up in their lungs. Again, I've already uploaded a video on D2L that goes through breath sounds. And when we go through our labs. We're going to be doing a lot of respiratory as well. So I'm not going to hit too much on breath sounds here, but we'll do them in person. We'll listen for breath sounds even on each other and to see if we're truly hearing it. And then we're going to watch some demonstrations in labs and in person on different types of breath sounds. Obviously, these are the ones that we're going to hear more common. Snoring, indicating potential airway obstruction maybe of the tongue, which is one of the most common. Stridor, potential upper airway obstruction as well, usually a foreign object. Wheezing, asthma patient potentially. Bronchi, which is like rattling a phlegm in the lungs. It almost seems like sounds like a rattler, like a baby rattler. Crackles, fluid in the lungs. Think of putting that straw in the glass and blowing into it, those bubbles that come up. And then a pleural friction rub. That'll almost sound like sandpaper rubbing against each other. Or if you ever, rub your hand along a rough surface, push pressure down, the noise that you hear, that's what you'll hear when you listen if you hear a friction rub. And that's, again, the surfactant between the layers of the lung, the lines of the lung, has diminished. Maybe due to dehydration, maybe due to an infection. So it doesn't hurt giving these patients a little bit of fluid as long as their blood pressure's within a normal state. Our secondary assessment, look for cyanosis, look for clubbing of the fingers. This is really important. Clubbing of the fingers indicates low blood concentration, low oxygen within the blood, hypoxemia. Remember, hypoxia is a broad term. That's just low oxygen. When we talk about hypoxemia, anything with emia is usually blood related, such as anemia. So we could potentially see what is called clubbing, and I've got a picture of it here shortly. Carpal pedal spasms. This is what you'll generally see in patients that are having anxiety attacks. Carpal pedal spasms are when their arms and their legs begin to go numb or they feel like they're very tingly. And that's because I guarantee, put them on end-tidal. Put the next person with having an anxiety attack on end-tidal. Their end-tidal will be low. That's why our treatment for these patients used to be, hey, let's give them a paper bag. Let's have them rebreathe carbon dioxide to bring their carbon dioxide level back up with a normal. They're feeling that tingling because they're losing oxygen in those extremities because the body is shunting it all to the core, shunting it all to the trunk. So I talked about clubbing. This is how a normal finger should look. Right? Normal fingernail, normal fingernail bed. Chubby finger with a small nail, I'm just saying. This is clubbing. When you get a downward deflection of the nail and it starts to round over the finger itself, that is a really good indicator of long-term hypoxemia. And you'll see this a lot of times in COPD patients that are severe. What are our vital signs telling us about the patient? Tachycardia usually indicates some sort of a problem, right? Unless you just got done running a mile. What is the respiratory rate? What's the respiratory pattern? Is it irregular? Is it normal? Is this due to trauma? Is it due to some sort of central nervous system issue? It depends on the complaint itself. Remember, tachypnea is fast breathing. Anything with PNEA or pnea is breathing. Apnea, breathing. So apnea is without breaths, right? Tachypnea, anything with tachy, means fast. So that is anything that exceeds 20. Remember, the normal respiratory rate for an adult is 12 to 20. Bradypnea is slow breathing. Anything less than 12, that's when we start to become a little concerned. Pulse ox, I'm not saying it's not a useful tool, but I'm saying it should be used in conjunction with an assessment. It should be used in conjunction with end-tidal monitoring if possible. A lot of times, though, with pulse ox, what are some things that can skew a pulse ox reading? Maybe we don't even get a reading. What are some things that can lead to that?
Fingernail polish and cold fingers.
Fingernail polish and cold fingers, the most common ones, right? Again, SpO2 just measures the amount of hemoglobin that is saturated. Please pound that in your head. It does not measure the amount of oxygen that is saturating hemoglobin. It is just the amount of hemoglobin that is saturated. Some places have peak expiratory flow rates to measure. If you've ever taken like a physical where you have to blow into this machine essentially, and they want to see how long you can blow into it and what your pressure is behind it, that's what they're going for, is to see what your expiratory flow rate is and how much air you're truly I think they call them maybe a PFT test. How much air you're truly expelling out of your system, and that'll be a good indicator as well of potential respiratory issues. Capnography. I cannot speak enough about it. Looking at your capnometry as well. Capnometry is a measurement of numbers. That's where capnography is a capnograph. That's when we begin to see our end tidal readings on a monitor in square waveform. We're going to go through this in person as well. I've got a cardiac monitor, and I've got end tidal for us to put on each other. And we're going to look at different respiratory patterns. We're going to look at the waveform. What's the waveform truly showing us? A lot of times, paramedics don't rely on that waveform enough. They don't think it's pertinent enough. Or the problem is they don't know how to truly read it. Even me, when I went through paramedic school, capnography was not something we hit on very big. It wasn't something that we used a whole lot, to be honest. But the times have changed. So we're going to cover capnography quite a bit in lab. Anytime you see PA, it is an arterial reading, arterial pressure. So partial pressure of CO2 would be represented PaCO2, as opposed to CO2, which is the end product of metabolism. That's the amount of the amount that you're breathing out, right? Some causes of decreased CO2 levels. Remember, normal level is 35 to 45. Anything lower, we are alkalytic. Anything higher than 45, we are acidic. So anytime we have decreased CO2 levels, they could be caused by shock, right? Shock is potentially hypoperfusion. Kind of makes sense. We have to have perfusion to have respiration. Cardiac arrest, obviously, because we don't have any respiratory drive at that point. A PE, because it's not allowing your respiratory system to do its job. We have a blockage in one of the pulmonary arteries. Bronchospasms, and then airway obstructions. Anything that can disrupt ventilation can lead to decreased CO2. As to where increased CO2 can be due to respiratory depression. So our numbers begin to decline. Respiratory failure, hyperthermia, because our body begins to slow down at that point. Know your end tidal numbers if you do not already know them. Colorimetric device, I use them. I'm not the biggest fan of them because they have ways that they fail, just like everything else equipment-wise that we use. They are pH sensitive. If you've ever seen a colorimetric device, most times it's used during cardiac arrest. They intubate the patient. They put this filter on top of the tube. It's usually gold or purple. If it turns gold, it means that we have good respiration. We're in the right area. The problem is that relies off pH. So as soon as it detects something acidic, it turns gold. Again, the issue is if there's any vomit that touches that filter, vomit is acidic. It will turn that filter gold, and you'll have a false positive for being in the airway. That's why the gold standard is end tidal monitoring with our patients. I'll talk about this in lab a little bit more because it's a lot easier to show you on a cardiac monitor. When we're looking at our capnograph itself, looking at our baseline, looking at our respiratory upstroke, our plateau, and then our phase where we start to expire at that point, and what we're truly looking for in our waveform. So again, we'll cover that in lab. It's just one of those things I can't show you over a computer. It needs to be done in person. With our respiratory patients, we should be monitoring end tidal all the way to the hospital. They don't have to be intubated to monitor end tidal. We can put nasal cannulas on them, right? Every service that I know of carries them anymore. They're really simple, really easy to use, and they're now even in the EMT scope of practice for you guys to use, to monitor. Why not use them? You can also put oxygen through them as well. I had somebody, you can actually place, somebody asked me if you can, and yes, you absolutely can. If you have a patient on CPAP, or maybe you're bagging a patient, you can put a nasal cannula in them still when it comes to end tidal. It'll still give you readings. So if you have them on CPAP, absolutely, still put an end tidal nasal cannula on them. Anytime we get ROSC on a patient, especially in cardiac arrest, cardiac arrest, we're going to see low numbers. We want to see at least a number of 10 when it comes to end tidal numbers, because that shows us we're still perfusing somewhat, and that's usually a really good indicator we're going to get ROSC on our patient. Anything lower than 10 is either a way that we can confirm death or our compressions suck. So if you are doing CPR and you have a number of 10, maybe 12, keep going with what you're doing. If you see that number jump, maybe 50s or 60s or 70s, check your patient because they're now breathing on their own. And the end tidal is picking up on a huge level of carbon dioxide because they went from metabolic to respiratory at that point. Check your patient if you have a major jump in end tidal because I'm guessing you have ROSC. Airway, always first priority. Absolutely. ABCs, airway, breathing, circulation. I cannot pound that in your heads enough, especially when it comes to testing. When it comes to National Registry testing, airway always comes first before everything else. We cannot move on if we don't have a patent airway with our patients. As EMTs also, we tried to maintain an oxygen saturation of 100%. We don't do that anymore. There's no point in it. You can over-oxygenate your patient. We look, as paramedics, a number between 94 and 96%. If they're at 94 to 96, do not put oxygen on them. Especially cardiac patients, too much oxygen can actually hurt them. And when we get into cardiology, you'll see why. Always provide, never withhold oxygen if your patient needs it, but please do avoid over-oxygenating your patient. Please avoid hyperoxia. I'm not going to hit too much on upper airway obstructions. We know it can cause them. Food, dentures, your tongue is a very big, that's likely the number one cause of an airway obstruction in an unresponsive patient is their tongue. Also can be caused by an allergic reaction potentially or anaphylaxis. So when we talk about airway obstructions or choking or anything like that, consider all these wide spectrum of potential causes. I always like the patients that say something stuck in their throat and they can't breathe, but they can talk to me and tell me that. That's not a total. There's a difference between an obstruction and a total obstruction. You can have partial and you can have total. Burn patients, always assume that there is going to be airway swelling. Burn patients, if there's an indicator that there's upper airway swelling, such as nasal hairs burned, maybe burning around the mouth, those patients unfortunately need to be intubated at that point. You need to protect that airway. No matter how with it they are, they need to be intubated. Look for hives, especially around the neck. Look to see if you see swelling around the neck. Look at their tongue. See if you start to see swelling within their tongue. Those are all really good indicators because once you lose the ability to get that airway, you're not getting it back. This goes back to CPR. Is conscious choking and you're doing the Heimlich and then become unconscious, we start CPR on those patients. And maybe try to remove it with McGill forceps if possible. Never stick your fingers within a patient's mouth. But you can, even on choking patients, if they're starting to go unresponsive, use a laryngoscope and see if you can see in there. See if you can see the obstruction. Use forceps and pull it out if you need to, by all means. I think I showed you guys that video from Night Watch last semester. It works. I've done it. If you've ever heard of ARDS, and ARDS really made a big comeback during COVID, which is adult respiratory distress syndrome. The problem with it is this is usually caused by a fluid accumulation within the lungs, almost like a pneumonia. The fluid accumulation actually causes severe atelectasis or alveoli collapse, kind of like CHF does. But this is due to an infection of some sort. So you have to correct the infection as well as removing fluid from the lungs. The problem is, and we saw this a lot with COVID, is that our patients were essentially drowning. That were experiencing adult respiratory distress syndrome. And our ultimate treatment in the beginning of COVID was, hey, we need to place this patient on a ventilator. We weren't really treating the cause. We were just trying to maintain the patient at that point. The mortality for adult respiratory distress syndrome is 70%. That is super high. Your organs start shutting down at that point when you go into adult respiratory distress syndrome because you don't have oxygen. You're not converting carbon dioxide to oxygen. Your organs are shutting down because of lack of oxygen. These are the patients you see on dialysis. These are patients you potentially see on ECMO because their organs are not functioning how they should. Crackles obviously can be oscillated in both lungs. Pulse oximetry, low oxygen sats. This is a disease itself. It's nothing that in the field we're going to diagnose. And we're just going to say, oh my God, this person has some sort of infection. They can generally have a temperature with this as well. What happens is their body essentially puts itself into a thyroid storm or a thyrotoxic crisis and tries to fight off the infection. It raises its temperature to try to kill whatever bacteria. If you remember, when we talk about like Pi4 and pyremia last semester, how your body raises its temperature to try to kill foreign invaders. And what happens is your body essentially starts killing itself at that point. Treat them with whatever you need to maintain that patient. IV fluids if you need them, but remember, these patients are potentially drowning already within their lungs. Do not give them fluid unless it is warranted. Cardiac monitoring. We want to know if this is a cardiac issue. ARDS will generally not cause any cardiac issues until late. It is a very late sign to start to see cardiac shutdown. Secretions, if you need to, especially if you're intubating these patients, use a soft suction right down the ET tube to remove secretions. If you need to put them on CPAP, by all means do it. Patients that are in severe respiratory distress like that, a lot of times, especially if they're decompensating, by tubing them, they might not ever come off that tube. We want to try to prevent that. And I know, so it depends on the paramedic you talk to, they'll tube anybody that has trouble breathing at all. That's not being a good paramedic. That's not being a patient advocate. Our number one rule in EMS is do no harm. Why would we try to cause further harm to our patients? Treat them, be the paramedics that we are, treat them first. If there is no other way, by all means, then you have to turn to some form of intervention such as endotracheal intubation. Emphysema, really common form of COPD, right? Destruction of the alveolar walls. So what happens is these alveoli, they're little popsicles again, or little grape clusters, begin to break down. What happens when they begin to break down is we don't get that exchange of carbon dioxide and oxygen. These are patients that live in the high 80s or mid 80s. Most common in men more than women. Again, cigarette smoking, obese, diet. These are all potentially contributing factors. Lifestyle, look at how they are living. I don't know how many times I've been on somebody with COPD and you go in the house and they just finished their third pack of cigarettes. It's unfortunate. When those alveoli become completely destroyed, the lungs lose their ability to exchange. Air then becomes trapped and is not able to be expelled. That's why those patients breathe through pursed lips. They create pressure, almost similar to PEEP. PEEP, again, is leaving a certain amount of pressure in the lungs to be able to bring air in and push air out. They've lost that ability once those alveoli break down. That's why you'll see patients with emphysema literally breathe almost as if they're whistling. They'll put their mouth in that little shape, and that's how they breathe. Emphysema can be treated. It can be hopefully not terminal for our patients as long as they change their lifestyle. A lot of times people with emphysema, you'll see that big barrel chest. A lot of times they're called pink puffers, if you've ever heard that term before. What that is because they have a condition called polycythemia at that point, which is increased count of red blood cells, so it gives them a pink hue. The reason they're barrel chested is because due to such increased muscle buildup from trying to breathe. That is literally an increase of respiratory muscles. That's why they have that big barrel chest. Generally, you can see clubbing of the fingers. You don't see this as common as you'd like to think. But again, that's due to hypoxemia or lower than normal oxygen level in the blood. Bronchitis, we're not talking acute here, we're talking chronic bronchitis, people that deal with it over long periods of time. Production of large quantities of sputum. This is the people that have a lot of phlegm buildup within the respiratory tract. It's not super terminal or anything like that. It can be treated, but again, the patients have to be willing to change their lifestyle. There's a good example here. Those are your alveolar end, those little grape clusters. You can see that mucus buildup. The problem is, as that mucus builds up, you lose the ability to exchange carbon dioxide and oxygen. A lot of times these are people that are coughing constantly, trying to get that phlegm out of their lungs. People with bronchitis or chronic bronchitis will appear almost blue or pale in color. They're called blue bloaters. So you have pink puffers for emphysema and you have blue bloaters for chronic bronchitis. Bronchi, remember that sound, is the larger airways, not upper airway, larger airways, and you almost hear that rattling. That is mucus rattling around within their lungs. It almost sounds like a baby rattle. I'm not going to talk a whole lot about heart failure until we get into cardiology. CPAP is like I love CPAP. It can be used on all your respiratory distress patients that you think absolutely need it, especially if your patient is getting tired of breathing. They have to be conscious. They have to be able to breathe. They have to be able to tolerate that mask. What I'll usually do with CPAP first is have the patient hold the mask to their face so it doesn't freak them out, because obviously you're going to put some straps behind their head. After they've done that for a little bit, I'm like, hey, can I just strap this here so you don't have to hold it anymore? It'll work the same. And they're usually in agreement because they're tired of holding it. But CPAP is like the last ditch effort before you intubate somebody. Don't necessarily need to give these patients any fluid. They've got enough going on within their lungs. TKO or place a saline locket itself. You might be able to give some sort of beta-2 agonist, such as albuterol, maybe a duodenum treatment, to try and open up their bronchus, to try and allow them to cough and maybe get some of that phlegm out, because it'll help them and it'll help their oxygen saturation as well. The other issue is giving a duodenum might not work the best either. It either works or it doesn't, because to truly work, that has to be able to get down into their airways. Well, if their airways is being blocked by mucus and phlegm, that duodenum is doing nothing. Asthma. I struggled with asthma really bad when I was a child. You can have acute onsets of asthma. You can have issues with it forever. Usually can trigger an asthma attack, such as anxiety, such as some sort of allergen or antigen itself. Cold air will generally put them into coughing fits. I remember that was a big issue with me. It was cold air. Whenever I breathed in, I'd almost have an asthma attack every single time. These are patients, again, we're doing our assessment on them. They generally have albuterol treatments at home. I know I did as a child. I had a home nebulizer. This is really bronchial edema, bronchial swelling. So those little tubes that go down to our alveolar sacs, and there is a picture coming up to it here shortly of what it looks like. Those tubes begin to shrink down. That's why asthma patients, we hear wheezing. Wheezing is lower airway constriction, as to where stridor is upper airway constriction. Some asthma attacks will resolve on their own, but if you go on a patient having an asthma attack, either assist them with their inhaler or be the good paramedic you are, put them on a neb treatment, calm them down, talk them down, because they're going to be anxious at that point as well. Good example of our asthmatic patient's bronchi. On the left, we have a normal airway, no issues, it's pretty patent. One in the middle, it's starting to close up. Asthmatic airway, normal asthmatic, they might be sitting like that normally, as opposed to a normal airway. And then during an asthma attack, we obviously have severe constriction. That's why we're hearing that wheezing. Status asthmaticus, if you've ever heard of status asthmaticus, is a severe condition that patients can have. It is essentially an asthma attack that you cannot get to resolve. I've had patients before in status asthmaticus that duodenum treatments won't do anything, albuterol won't do anything, and they're just crashing hard because they're getting tired of breathing. Those patients honestly might need intubated. CPAP, obviously you can try, but they might end up needing intubated. There's something very distinct about asthma attacks or bronchospasms if you put these patients on end-tidal, and that is that they will almost have a shark fin appearance when we look at the graph itself. So please, when we talk about bronchospasms and airway obstructions, remember a shark fin when it comes to their graphs. When you see that shark fin, think asthma. Obviously, we want to supply supplemental oxygen to them, just enough to get them over that hump. We don't want to over-oxygenate our patients. Maybe we can give them some solumedrol, some dexamethasone, some sort of steroid to reduce inflammation of their lungs. Doesn't happen the easiest or the quickest. A duoneb is mainly going to be our go-to with these patients. The ipratropium bromide is really going to dry up some secretions as to where the albuterol is going to open up their airways and allow them to cough a lot of that up. And then obviously, if you need to follow up with any medication after the duoneb, just follow up with albuterol treatments. Most protocols will say after the initial duoneb, just do albuterol treatments following that. Depends on the nebulizer that you have, whether you set it at 10 to 15 liters to truly get a good nebulized mist coming out of that nebulizer. So be familiar with the equipment that you're working with. And then here you go. Status asthmaticus patients. Recognize respiratory arrest is imminent. Prepare for endotracheal intubation. There is no other way to fix what's going on with them. I'm going to skip over upper airway infections and jump right to pneumonia. Infection of the lungs, again, we're very, this is a time where pneumonia is pretty prevalent, especially when we're talking about a lot of our COVID patients, because a lot of our COVID patients were ending up with pneumonia, right? Which was an infection of the lung due to some sort of antigen, right? Risk factors, we're used to them. Obesity, smoking, what's their lifestyle like? So you get these infectious agents that invade the lungs. They have an increased mucus production. What happens with increased mucus production is that now we have too much within our alveoli or too much within our bronchi, and our patients again are essentially drowning with pneumonia, especially if it's really severe, especially if you were seeing a lot of COVID patients. Maybe that if you worked in a hospital or you were transporting a lot of COVID patients, you were seeing a lot of this. And they were doing their best to treat it. They were giving them infusions, they were giving them antibiotics in hopes that that would fix what was going on. But a lot of times it was terminal with our COVID patients. Non-COVID pneumonia, they treat with antibiotics at home. Yeah, you're going to probably have some chest pain and some issues breathing for a little while, but generally they can get it cleared up pretty quickly. Difference in pneumonia. I'm not going to go too far into the different types of pneumonia, but you can see here in our diagrams how it affects certain alveoli. These purple are the alveoli that are affected. So they're essentially dead at that point, or they have too much mucus in them, which will not allow them to function. You can see in this instance here, the alveolar space is smaller than it should be. And then the bottom one, that is essentially just fluid in the interstitial space outside. I don't know why I did that. Outside the bronchus and outside the alveoli around here. Pneumonia is very spreadable between one lung to the other. Infection may involve the entire lung itself. And the problem with that is it'll go right up our bronchus, go over that hill of a carina, and go right down to our other lung. You get bilateral pneumonia, and that is a sick patient. Again, this is a lot of times fluid builds up or mucus buildup, so be careful giving these patients fluid. Another thing that you'll notice with people with pneumonia is they'll generally have a fever of some sort. Another way you can tell is if they have like a night fever or they have chills at night. You know, they're really shaking a whole lot and they're having trouble breathing. There's two things I suspect when that happens. I suspect tuberculosis and I suspect pneumonia. Either way, I put a mask on with those patients because I'm not sure, well, in this time we wear masks no matter what, but I'm not sure what they truly have. If they're usually spitting up, this is the different, they're coughing and spitting up some sort of yellow or brown sputum or phlegm. That's a really good indicator that this patient has pneumonia. Sometimes if it looks like they're coughing up blood, it's probably because they are, because the linings of their lungs, the linings of their bronchus are so irritated because they're constantly being used due to coughing that you will potentially see blood in their phlegm. So anytime you have any sort of respiratory issue associated with a fever, think pneumonia, and think possibly some sort of infectious disease as well. They're going to do an x-ray to determine if it's pneumonia or not, and I believe I do have a x-ray on here, not pneumonia, but just to show you what a normal x-ray looks like on a patient. It's not something we normally deal with, but it's something that's pretty neat, especially if you work in a hospital, to be able to look at x-rays and then determine what's going on, especially within the patient's lungs. Severe cases, these patients might require ventilatory assistance. Remember, establish access, give them fluid if need be. Don't give them more than you need to, because you can worsen it. You can make that mucus buildup worse. I am not going to go too in depth on SARS and SARS-CoV because that is coronavirus, that is COVID. I think we've spent enough time on that over the last 2 years to know what's truly going on with our patients. Here's an x-ray. Now, this is a patient that has lung cancer. How can I tell this patient has lung cancer? Normally, you see this gray, these masses right here. Try to outline them. Those normally aren't there. You usually have a hue of gray, kind of like the smoke, all the way up like all this. It looks like just faint smoke in their lungs. That's pretty normal. That's usually indicating that we have air within our lungs. If you saw an x-ray and their lung, this whole area here, was completely black, or part of it was black, that means that there is no air movement within that. So like a collapsed lung, that whole space would be totally black. You won't be able to see the ribs. Obviously in this diagram as well, we've got our clavicles. We have our heart right here. And we have our ascending aorta right here. X-rays are pretty neat to look at. I'm not sure why, I just kind of enjoy them. Symptoms, SARS, we should all know these because it's been happening for 2 years with our patients. We've been transporting COVID patients. Sore throat, chills, fever, cough, respiratory distress, potential respiratory failure where the patients were essentially on a ventilator at that point. How are we treating them? We put them on high flow oxygen and we get them to the hospital. Maybe start an IV if we feel it warrants it. That's it. These patients need to be treated in the hospital. There's nothing pre-hospital that we're going to do for them. If suspected patient has some sort of SARS virus, notify our receiving hospital. In the beginning, we did that really diligently. Now it's just become something normal at this point. I'm not going over MERS because it's not anything pertinent to your guys' education, to be honest. Lung cancer, if anybody knows anybody that's had lung cancer, my grandfather passed away of lung cancer. It's a terrible thing to have because it begins the deterioration of your lungs and you essentially begin to starve for air at that point. Depends on how progressed the lung cancer is within the patients. Generally between ages of 55 and 65, what you were noticing is after 9/11, a lot of the first responders that were at ground zero had developed lung cancer afterwards, just due to the carcinogens and due to the toxins that were at ground zero. So environmental exposures to asbestos, there's a reason we remove asbestos from all homes and we don't use any paints that contain asbestos or anything like that anymore because we found out, hey, it's harmful to us. Any fumes, so this is a concern as well, people that work around fumes constantly. Maybe they work around like a tire manufacturing facility such as like Firestone, people that like paint for a living, people that paint vehicles for a living. That's why they have to wear certain respirators as well so they do not get those exposures. And OSHA has pretty well nailed that down. Issue with lung cancer again is that it starts tearing at our lung tissues, it starts tearing our bronchial tissues until we can no longer exchange carbon dioxide and oxygen. Generally, you'll see some sort of a mass, carcinoma is what it's called, and it's essentially this cluster of cells that are essentially cancerous, or if they do a biopsy and determine it's non-cancerous, they would call it benign at that point. You can also have a tumor within the lung as well. Prognosis depends on how far progressed the patient is with lung cancer. Severe uncontrolled hemoptysis, remember, is Coughing up blood can be a life-threatening presentation. Anytime somebody is coughing up blood, start to become a little bit concerned, especially if it's massive amounts of blood. Profound weight loss, crackles. These are just sick patients. They'll know they have cancer. We're not diagnosing lung cancer in the back of an ambulance. Unfortunately, these are sick people. And if you've ever worked in a service that transports patients or maybe does transfers, then you've dealt with somebody with cancer at some point. It's just a horrible disease process to watch people go through. These are also the patients we need to be asking about a DNR at that point, especially if we think they're having severe problems. Do they have a DNR present? What is their advanced directive? If dehydrated, give them normal saline. Follow your protocols for how we're going to treat these patients. We've got like 25 slides left, so hang on with me, guys. Toxic inhalation, this could be fumes, this could be superheated air, this could be super chilled air, steam, potentially causing upper airway burns, potentially causing upper airway irritation, depending on what the chemical itself is. Some examples of acids or alkalis, ammonia, obviously. Chlorine is a big one as well. Nitric acid, sulfur. Our bodies pick up on those really quickly, and if we're in an exposed environment with massive amounts of this, it is detrimental to our health. That's why whenever, if we have a vehicle that's transporting any sort of chemical like this, that's why we don't run up and if there's a vehicle accident, we don't run up and try to pull these people out of a vehicle. It's because there's potential that we could get harmed as well. And I'll show you guys a video if you've never seen it before at some point of that happening. Determine how long the patient was in the condition. How long were they exposed to this environment? This could potentially be where the patient is being transported to a hyperbaric chamber. Look to see if they have any burns or any sort of irritation to their mouth, throat, or face. Listen to their lung sounds. What are their lung sounds telling you? Do we have lower airway constriction, such as wheezing? Do we have pulmonary edema? Do we have those crackles? That straw in the water sound? Best thing you can do is get the patient out of that environment. Administer humidified oxygen if necessary for possible irritants. Transport them to the hospital. Biggest thing we're going to do is maintain these patients and keep them comfortable and get them to the hospital really quickly. Carbon monoxide, same thing. Odorless, tasteless gas. Generally, a lot of times you'll see this. Maybe gas leaks inside of a house. Maybe somebody left their burner on and didn't have a flame. Maybe we've got water heater issues. Who knows what it is? Number one cause of poisoning in industrialized countries is due to carbon monoxide poisoning. If you've ever seen a patient almost try to commit suicide where they do it in the garage, you leave the vehicle running in the garage, the exhaust buildup creates a toxic environment, carbon monoxide, and essentially their body begins to shut down because they're not breathing in clean air at that site. Carbon monoxide poisoning allows our hemoglobin to no longer transport oxygen. Oxygen no longer binds to our hemoglobin when we have carbon monoxide poisoning. These patients, again, need a hyperbaric chamber. How they will generally present is almost bright cherry red. This is the word I was looking for, because they have such a buildup of hemoglobin that has nothing attached to it. They have such a massive buildup of the red blood cells that have nothing attached to it. You'll know, especially if it's a potential CO call. That's why a lot of EMS agencies, and if you don't, maybe talk your department into it, carry a gas meter on their bag, on their first out bag. You go into a place to treat somebody with a respiratory problem, having trouble breathing, and that alarm starts to go off, bingo, you found the cause. A PE. This is one of the most terrifying things you will come to with the patient, especially if they're having severe difficulty breathing and chest pain, because a PE can turn deadly pretty quickly. And there are some things that potentially are risk factors to PEs. Does anybody know or can name some of the risk factors of somebody having a PE by chance?
Surgery.
Okay, so a recent surgery, right? Okay, what else?
Sitting
Long
down.
time.
Sitting down for too long. You'll see that a lot of times with people traveling, flight, or even truck
Flying.
drivers, to be honest. Flying.
DVTs.
What was that?
DVTs.
Yeah, deep vein thrombosis. And that's honestly one of the things I look for on patients as well is if they're having trouble breathing, I hate to say this, look at their legs. If their legs are exposed, do they have any spots that are warm and red and hot to the touch? That could potentially indicate either an infection or a possible DVT, especially if it's really hard to the touch. PEs, there's really nothing we are going to do for these patients. What we need to do is get them to the hospital as quickly as possible. And I'll show you guys when we get into cardiology, some neat tricks to be able to potentially identify somebody that's having a PE. But yeah, risk factors, as well as use of birth control. That can lead to potential PE as well. Atrial fibrillation, there's a reason that people with AFib are on blood thinners. And it's because their heart beats sporadically. So blood could pool up in their heart, and then they get one big squeeze, and that blood that was pooling had become a clot and then now got thrown, and that clot gets lodged in their pulmonary artery, potentially leading to respiratory arrest. And these people are essentially dry starving, if that makes sense.
Is there going to be a time? Is there going to be a time when we add COVID to that list?
Yeah, no kidding, right? They'll present like our respiratory distress patients, labored breathing, fast breathing. They'll feel like, again, they're having severe chest pain. A lot of times the PE patients, their pulse ox will either be dropping and you cannot get it up. There's nothing you can do to get it up because there's a blockage, or their pulse ox will remain consistent and it's not dropping, it's not raising. Most of the time you'll see a pulse ox dropping that you can't correct. In up to 50 cases, a DVT is potentially present. So again, look at their legs. A lot of times DVTs come from the legs. Very warm and swollen, potentially hard area, anywhere from the ankle up to the thigh, that could potentially, that if they're having DVTs and having difficulty breathing, boy, that raises some red flags in my mind, to be honest. With these patients, ABCs are priority. If the patient becomes unresponsive and goes to cardiac arrest, the chance of getting somebody back with a PE, unless it dislodged, is slim to none. They need surgery. And I've got a great video I'll show you guys, or I'll upload on D2L. You know what? Actually, I'll go through it with you next week. On a PE that was removed from somebody. And it's one of the most terrifying and exciting things I've ever seen. They need surgery. They don't need some in the back of an ambulance. If need be, and you're not able to maintain this patient's ABCs, obviously we can turn to endotracheal intubation, but that's really not fixing anything with these patients. Again, they need rapid transport to the hospital. Monitor them. Please, for the love of God, if you think they're having a PE, keep them at least on a 4 lead. We should be doing a 12 lead with any respiratory patient as well. And again, when we get into cardiology, I'm going to tell you guys, and I'm going to show you guys how you can potentially see a PE on a 12 lead. Spontaneous pneumos, again, tall, lanky type males, usually younger males, 20 to 40. If they start having spontaneous pneumos, they have a really good chance of developing COPD later on in life. This is not due to any trauma. Again, it is just spontaneous, where their lung essentially collapse due to a brush, maybe with their chest wall or whatever it might be. They won't essentially be complaining of difficulty breathing at first. It'll be more of a sharp stabbing type pain, if you've ever heard of that before. But if you tall, lanky, again, consider a spontaneous pneumo until proven otherwise. They need a potential chest tube, maybe a needle decompression, depending on how severe the patient is. I usually won't talk about needle decompressions with patients that are having spontaneous pneumos. It's usually not warranted because there is no trauma, there is no pressure. It's just they have a lung that's not functioning correctly. You can still operate with one lung, I promise. Rapid breathing due to anxiety is associated with hyperventilation syndrome. This is where they start to get the numbness in their arms and legs, their carpopedal spasms. If you ever go on an anxiety patient, one of the first things I ask them to determine if it's anxiety or not is, hey, do your arms and legs kind of feel like they're going numb? And they're agreeing with you 100%. Yeah, that's what's going on. That tells you right there, it's probably, it might not be anxiety, but it's because they're breathing too fast. They're withholding too much carbon dioxide. Primary treatment reassurance, talk the patient down. This I'm going to reserve for when we talk about the central nervous system this semester, which we cover in one whole chapter. So we're going to bypass that as well. That perfect. All right. What questions can I answer for you guys? I tried to get through a lot of this. A lot of it was a review, and a lot of it is stuff we're going to be covering so much during lab. And again, I'm really excited for this semester. This is the semester where I really start to have fun. I start to really be able to teach you guys some things that really sets the foundation for you as a paramedic. I get it. Last semester is kind of boring. We talk about cells, we talk about diffusion, we talk about osmosis. But a lot of that isn't pertinent stuff that I expect you to remember. There is certain stuff, absolutely, and I'm not saying don't remember any of it, but don't dive in too much to it. Don't dive into where you don't need to. Don't make a mountain out of a molehill. This semester is very important when we start talking about medical emergencies, again, with all the conditions we're going to cover. And then next semester is obviously just kind of like a review of medical. We go through all of our card courses, ACLS, PALS, PHTLS, AMLS, GEMS, Texas A&M, coming up here for their hazmat class. So don't dive too deep into that. I'm excited. I love cardiology. It's my forte. I'm excited to be able to teach you guys cardiology. I'm excited for you guys to be able to send me 12 leads finally when you're out in ride times during clinicals. If you're not sure about something, please, when we get into 12 leads, because I'm going to open up cath lab and cath lab recovery for you guys to be able to go to after cardiology or halfway through cardiology. Please do not hesitate to send me something or send me an interesting patient or something like that. I love those. I love talking through them, and I love explaining to you guys what's happening with the patient. Any questions for me before I let you guys go for tonight? Again, short night. I'm going to try to keep them between 2 and 3 hours. That's how I've laid out my schedule, just to help you guys retain some information. Tanya, you got a question?
Yeah, my question is, so can we, let's say we want to listen to your class, can we go back and record it or listen to it or no?
Absolutely. I will post the day after. It has to save, but the day after I post it in D2L under my class. So just go to the chapter that we talked about, and the recording will be in there.
And I also was looking at your syllabus, and it says that we have to upload, there's an access code for the Brady.
Yes. I haven't set up the MyBrady yet, and honestly, I don't think I'm going to use it for homework for you guys because I think it's a little. I've got so much other stuff for you guys to do this semester with medical emergencies, worksheets and stuff that I have. So I'm not sure if I'm going to use it 100% or not for homework for you guys. So I'm still deciding on that, but I don't think I'm going to use it for homework for you guys. So those chapter tests and chapter quizzes, I'll open it obviously so you guys can use it for review, but I might not use it a whole lot. So.
Okay, that was my other question. Thank you.
Yep.
Hey, Rudy, just making sure. We have classes Thursday, don't we?
Yes.
Okay.
And I think there is 12 people this Thursday night, if I'm not mistaken. And I think we're only in 2-hour sessions. So there's going to be some nights, honestly, that we're cramming so much stuff in 2 hours. And there's going to be some nights where we're getting done in an hour and 45 minutes. But we'll make do. And again, this is the exciting semester. This is the semester when I get to really make you guys into paramedics. Anybody else?
Hey, just a quick question. I haven't been able to look at one of our CPAPs yet, but is there a way to nebulize through a CPAP?
Absolutely. Oh, absolutely there is. There's usually a separate port that your nebulizer will fit into. And some CPAP masks, whether you're using like a GoPAP, which is the really easy one, or an EasyPAP, will have that already built into them. But yeah, absolutely, you can nebulize into CPAP treatments. And we're going to be doing a lot of that during lab sessions as well, is demonstrating and working with CPAP and basic settings on ventilators and like auto vents. So I know up in Mason City, the deputy chief of EMS has offered up one of the vents for us to play with while we're up there. So I'm pretty excited about that. And again, we'll demonstrate how to nebulize through a CPAP. Good question. Anybody else? All right, if there's no other questions, to the people that joined my class this semester, welcome. I'm excited to have all of you. Again, this semester is a blast. hopefully you guys have as much fun as we do instructing it. So if you have any questions during, honestly, email me. Email is the thing I probably check the most out of anything. Or you can honestly, sometimes I don't have that clinical phone on me. Like during break, I honestly didn't carry it around a whole lot, but I check text messages on it. If you want me to call you or something like that, shoot a text message to that clinical phone. I might get back to you in a day or two, but emails I usually check every single night. So if you guys have any questions, please shoot me an email and I will absolutely address it as quickly as I can. Other than that, if you have any questions, you can hang out. If not, have a great rest of your night. I'll see some of you Thursday night, and the rest of you up in Mesa City, I will send you the schedule tomorrow on when your lab days are. Have a good night, guys.
Thank you.
Thank you.
I might have missed. Was the test open for this chapter?
Sorry, I had myself muted. I'm gonna actually open it up after next week because some of the stuff that was in this chapter I'm gonna cover a little bit at the beginning of next chapter. So don't worry about getting completed between now and then.
All right, thanks.